All right, guys, we're gonna go over what you need to gather for chest tube insertion. So you are going to plan on placing a chest tube with anybody that has a hemothorax, a pneumothorax, tension pneumothorax, any needle decompression, going to need to place a chest tube. So what you're going to need to gather is the blue chest tube insertion pack. This is the new chest tube insertion pack. It is not the old mint green Trocart tube placement. So we're going to be looking specifically for this one. Both of our bays should have those stocked only. You're also going to want the correct size chest tube for the child. You can consult the Broslow book, the Broslow tape, or the pink medication book. You want to make sure that the chest tube you choose, double check to make sure it says straight on it, okay? These tubes are hollow. They have more holes at the end here to allow for drainage and a sharp tip, and they are hollow on the inside. An incorrect tube are the sharp tubes. These have this large metal trocar in the middle. They also have fewer openings for drainage. Our smaller infant-sized tubes are currently in the process of being converted to the straight tubes. Our larger child tubes should all be the straight tubes and not sharp. To set up the Pleur-evac, what you're going to need is a functioning, completely set up suction setup. You're also going to need your Pleur-evac, which is located up in the cabinets. Make sure your suction is on, set up. You would open this with your PPE on. Chest tube insertions, especially if you have a hemothorax, can be very bloody, so make sure you have eye protection on and that you're donning the correct PPE to avoid any exposure. It's also inserted sterilely, so you want to make sure that you're following sterile process as much as you can here. All right, so to go over our Pleur-evac here, this is a water seal. All right, it's a closed drainage unit. We have a water seal here. And then we have our pressure here. So all chest tubes are going to be set automatically to a negative 20 centimeters of water. All right. And this can be adjusted with a dial on the side right here, but you are not going to adjust this unless you are ordered by a physician. So every size is pretty much going to be a negative 20. We have a swivel base at the bottom for setting it up straight. Once this is open and ready to go, you'll take your water ampule on top. Sterile water here. You are going to open it and you're going to fill the suction port with that water, and you should see it fill up to 2 centimeters. So make sure it is completely empty in there. You don't want to spill this at all. So be careful to make sure that this is standing upright, all right? The physician will be inserting the chest tube at this time. Make sure we have pain medication considerations. This is a very painful procedure. So lidocaine when applicable, and any, fentanyl or morphine or whatever you would use for pain control for the patient. You want for the chest tube site, you want a Vaseline gauze around the insertion site to prevent any air leak, and you're going to cover that with foam tape, okay? Once the physician has inserted that chest tube, they are going to ask you for the drainage tubing, all right? They are going to ask you to remove the cap, make sure this end stays sterile, and you will hand the tube to the provider who will then insert it, and you will dress it and help them suture it in. Suction will then be connected. So grab your suction, make sure it's set at continuous. All right, it doesn't need to be super high. I say medium continuous suction. What you don't want is intermittent suction. You want it to be set at continuous. Once this is set up and the chest tube is inserted, you're going to connect your suction tubing to the suction port where you inserted the water, okay? It's not going to suck out your water. It stays right here, all right? They're going to insert the chest tube, and you should watch for titling. So you're going to see the level go up and down here. This little ball should rise and fall with inhalation and exhalation. That's normal. You might at first see some bubbling in the chamber. What you're watching for is excessive bubbling or a sudden cessation in bubbling, which could indicate that we have a leak or a pneumothorax. So always looking at your patient when you're monitoring those things. Do they have signs of distress? Are they tachypnic? Do they have equal rise and fall of their chest? Are they air hungry? What is their color looking like? To make sure that what you're seeing actually correlates with what your patient is doing. You have two ways that you can stand this up. You can use the swivel stand at the bottom here. This does tend to get knocked over in a busy trauma bay, and the side rails do tend to dislodge the tubing. So I want you to be very cognizant that in a crowded room, your chest tube, protect it like you protect an airway, okay? So always making sure that this is safe when you're moving the patient, when the side rails are coming down. If you don't want to take the chance with the kickstand here, you can use the hangers on the side, and I will hang these from an immovable part of the bed, so like the frame, and I will not put it on the side rail. What you want to make sure is the unit stays below the site of where the chest tube has been inserted. Make sure that there are no dependent loops. Make sure that there is nothing occluding the tube. You don't want there to be any kinks. You do not want to clamp the tubing. When you do these things, it puts them at risk for tension pneumothorax. This is going to be inserted at the chest tube site. If you have a rush of fluid or blood coming out, make sure with a permanent marker that you are writing the level. All right, so put a little line at like 200 mils, the time and the date at which you see that. And if you see a sudden gush of fluid where it's more than like 200, 100 an hour, you're going to tell a physician immediately. They may need to go to OR. When placing chest tubes, I want you to always have blood products ready to go. If they are having large hemothorax, you're going to need to replace that volume. They will likely need to go to the OR to make sure that hole is fixed wherever they're leaking from. Again, we're monitoring for signs of tension pneumothorax, so tachycardia, tachypnea, low O2 sats, air hunger, cyanosis. These are very insidious. Sometimes they can be very fast. What you're going to see very late in the game is the tracheal deviation or even a change in the pulse ox. That pulse ox delay, pulse ox latency is very real. So considering end-tidal is going to give you a very real picture of what that ventilation and perfusion status is doing. If you have multiple chest tubes, so let's pretend we have 2 chest tubes on either side, you might be able to, what you will do is connect to one suction container, and instead of this single guy here, you would replace it. You might need some forceps for that. You can get that out of the chest tube insertion kit. But you would replace it with the Y-site connector, okay? So the Y connector, and you can put a chest tube here and a chest tube here, okay? Again, being very, very careful of dislodgement. If your chest tube does become dislodged, you're going to cover the insertion site with a gloved hand, and you're gonna call for help immediately. And they will need to replace that, okay? Always have your intubation supplies ready to go, and just continually watching and reassessing your patient. If you have any questions, please let me know.